Here. Should we wait until 05? Do you think that's okay, Linda, or should we get started in the next minute?
Why don't we go ahead and get started since we have a couple of introductory slides?
All right.
Okay.
Well, welcome
Great.
everybody. And Linda, I'll give you the floor now.
Okay, thank you so much. And thank you to everyone who's joining us from wherever you are in the world. We're so delighted that you're here today. This webinar is going to serve as a launch of a series of operational briefs and decision tools that the Global Financing Facility developed to support World Bank task team leads to include school health and nutrition as part of their investment projects. And please don't be concerned if you're joining us from beyond the World Bank, because these tools, as they were being developed, were really written to be useful for both an internal and an external audience. And we hope that you find that to be true. My name is Linda Schultz, and I presently serve as a senior operations lead at the Research Consortium for School Health and Nutrition, which is hosted by the London School of Hygiene and Tropical Medicine. And the work that I'm describing today is from my previous employment with the Global Financing Facility. I'm so pleased to be presenting today alongside my colleagues, Brendan Hayes and Julie Ruel-Bergeron. Brendan Hayes is a senior health specialist and the technical lead for at the Global Financing Facility for Sexual and Reproductive Health. Brendan led an analytical investment that was looking at adolescent and sexual and reproductive health, and it's from that investment that these briefs were developed. Julie is a senior health specialist, and she oversaw the school health and nutrition arm of that investment, and you'll hear a little bit more about that in just a moment. We are also so delighted to be joined by some esteemed colleagues in this space. We have Fatima Berry, who is with the Health, Nutrition, and Population Global Practice here at the World Bank, and also by Jeannie Long from Save the Children. And I will give them a proper introduction when we come to our panel discussion. Our webinar today is going to cover 4 main areas. The first is to explain why it is the Global Financing Facility honed in on school health as an opportune intervention to improve the human capital of adolescents. We're also going to talk about the rationale for why you might deliver health interventions through schools. Then we're going to walk you through the methodology and give you a flavor of what our briefs cover. And lastly, we're going to hear from our panelists who will reflect on the briefs and draw upon their experience in this space to explain what it is that they see as the value and what's missed by these tools. We're also going to break for questions at 2 points. Just 2 very quick housekeeping notes. The first is that this session was advertised as an hour-and-a-half session, but actually we will be concluding at the hour. And secondly, because of the format that we are using, we will be asking you to put your questions in the chat, and our colleagues will be monitoring the chat as we go along so that nothing is missed. You're going to hear today that school health and nutrition is an exceptionally multi-sectoral intervention. And because of that, we're really curious who's amongst us. This isn't simply idle curiosity. We want to be tailoring what it is that we say to who's amongst us. So if you wouldn't mind just answering 2 quick questions describing what sector best describes where you sit and what brings you here today. My colleague Fernanda will be putting a link in the chat.
I just included it. Thank you, Linda. If anyone has a problem accessing it, just let us know. Should we share the screen now with the results as they go?
Sure. I'm not sure if you publish it, will it appear?
Let me do that if that's, if I have it here.
All right, let me stop sharing for just a moment.
All right.
Okay, so overwhelmingly health, that's great. We can really highlight some of the health elements as we go along, and great to see that we also have some education folks with us as well, since this is really very much a health and education intervention.
I'll just click the next slide so we go to the next question and people will be able to answer this one as well.
Brendan, I see your hand up.
That's just me trying to switch between screens.
Okay. Okay, great. So I think we've got quorum here. So amongst us, we have folks that support projects that are related to school health and nutrition, and others that are curious to have some guidance about multi-sectoral programming. So I think that we are really amongst, you've come to the right place, and I hope that you find this session very useful. I will go ahead and share my screen again. Oh, sorry, Fernanda, I think you have to stop.
There you go.
Okay, there we go. All right, and again, please tell me if, okay, I think that's right. Okay, so I'm going to hand the floor over to Brendan at this moment.
Thanks very much, Linda. So let me just, in terms of sort of setting the scene and framing this discussion, I'm going to take a little bit of a step back and talk about how we landed on a series of tools to support school health and nutrition interventions as part of the Global Financing Facility's collaboration with the World Bank. So as many of you know, the GFF, the Global Financing Facility, was launched in 2015 to accelerate progress on improving health outcomes for women, children, and adolescents. But looking across the life course, there was a recognition that the adolescent kind of age period was one in which there was very limited investment. A 2018 study that looked at development assistance for health found that around 2.2% of OECD financing was being allocated to adolescent health issues. And this is in contrast to an estimate around the same period from WHO that put the global disease burden, the share of the global disease burden that was attributed to either life events or behaviors that developed in the adolescent time period at 35% of overall burden. So a huge mismatch in the investment going into adolescent health issues and the contribution that the adolescent time period, this very vulnerable time period in many ways for boys and for girls, was contributing to the burden that health systems were facing. So the GFF always had a mandate to focus on adolescents, and in the early years of the GFF, there was a recognition that this kind of focus on adolescent health investments was not happening in the most systematic way possible. So in 2018, we convened a technical advisory group, and this was drawn from members of our investors group to have a discussion around what the GFF's role in this space should be. And there had been a recognition that, you know, adolescent health interventions, there have been a lot that have been done on adolescent health, but a lot of the work on adolescent health, particularly the innovative work, had really been happening outside of government systems, often for very good reasons. Parallel system investments in the early 2000s were really in response to in some cases, a lack of interest from governments in investing in this life stage. But there was a recognition that really to take things to scale, there really needed to be a closer integration or a closer attention paid to the system side to this challenge. And this was one of the key recommendations that came out of this technical advisory group, was that the GFF and its partnership with the World Bank was a great platform for trying to address the kind of systems for unlocking greater scale in investment for adolescent health and nutrition. And this was articulated in an approach paper that was presented that year to the GFF investors group. And this led to a kind of closer collaboration with HMP and social protection and education in the form of a global programmatic ASA that was initiated towards the end of the 2019 fiscal year. And that programmatic ASA covered a whole range of different topics, but within that ASA, we identified the school health platform as a really great opportunity for trying to unlock greater scale for adolescent health and nutrition interventions. We'll talk a little bit more. Linda will talk you through the kind of development process, but that was really the sort of origin story of this work and where it came from and what we're trying to support and achieve. And that is really increased investment and increased scale at delivery for adolescent health and nutrition interventions. Thanks, Linda.
Okay, thank you, Brendan. I will now pass the floor to my colleague, Julie.
Thank you so much, Linda, and thank you, Brendan. Thank you as well to all of the participants who are here with us today. It's great to have you in this webinar, and thank you for joining us. So just to kick things off, I think the rationale for school-based health and nutrition programming for adolescents is quite clear. And this is because it presents benefits or even incentives for both the health and education sectors. You can see that in this circular image on the right here, but first, we know that adolescence is an important period of biological development and social change, during which many lifelong health behaviors are formed and gender norms are solidified. And these can actually last not just through the life course, but also into the next generation. So this creates the cyclical relationship where investments in health and nutrition in adolescence improve the ability of adolescent students to benefit from educational investments while also reducing morbidity and positively influencing social and gender norms. So we can say that healthy students achieve better educational outcomes, which are then in turn associated with improved health literacy, acquisition of life skills, and health outcomes. Next slide, please. The use of the school platform for health and nutrition service delivery is not necessarily new. Here we present on the left-hand side of the screen the theory of change, essentially, for school-based health and nutrition interventions. But there's essentially 4 key reasons for which these investments make sense. First, we could talk about access. The global gross enrollment ratio in lower secondary school has reached almost 85%, and an increasing number of adolescent girls are enrolling in secondary school. This means that this platform is going to be the only setting that reaches a large proportion of beneficiaries on a nearly daily basis during this critical life stage. Second, we can talk about timing. So school-based programming is typically widely accepted among students, parents, and communities because the services are free at the point of use. They reduce health disparities and reduce the reliance on health facilities for preventive services. So this provides, this very unique opportunity to target causes of morbidity during these periods of tremendous physical and cognitive development. Third, we can talk about human capital benefits. School-based health interventions benefit the learner, as I've mentioned, their learning capacity, and these subsequently increase their capacity to build human capital, which then has these downstream effects on their offspring. And lastly, we can talk about cost effectiveness. So school-based delivery reduces implementation costs and maximizes efficiency by building on existing infrastructure and curricula, which also enables the sustainability of this intervention through integration within national education sector plans. Next slide, please. So despite the strong rationale for school-based health and nutrition programming for adolescents, this is an area that continues to receive inadequate attention and investment, specifically globally, especially when we're talking about large scale, which is what Brendan was alluding to. And so under the analytic work that Brendan was also describing, we proceeded to try and understand what might be useful specifically for World Bank task team leaders, but also more broadly, those implementing adolescent school health and nutrition interventions globally. So really trying to assess what would help them to promote policy dialogue on this topic at the country level, and ideally, how meeting these needs might then yield greater investments in adolescent school health and nutrition globally. So for that, we conducted focus group discussions with task team leaders across the health and education global practices. And this was really to identify what the demand and content was going to be for operational guidance that would support that policy dialogue and programming. Those consultations highlighted the need for operational guidance that was going to be specifically on, first, the evidence base for adolescent school health and nutrition programming. Second, guidance on, what interventions are we talking about and what's the right mix of interventions, how to select, how to build your package essentially. Third, monitoring and evaluation considerations. Of course, the results framework is always a difficult part of any program development. So, that was highlighted as another need. Fourth, the use of World Bank instruments and their application and financing for adolescent school health and nutrition. And then lastly, a decision tree that could walk TTLs through elements of adolescent school health and nutrition from kind of the policy stage all the way through programming and including financing. So next slide, please. So with that, that is what we're here for today, is to present some of these tools that were actually all of these tools that were developed. And in this next section of the presentation, we're going to showcase some of the kind of highlights of these operational tools that were developed. You can access each of these tools on the GFF website, and I believe Fernanda, has already, she's so efficient, already put the links up in the chat so that you can access them easily. Next slide, please. I'll be presenting, oops, that was one too many. There we go. I'll be presenting the first brief, and this one includes the evidence base for adolescent school health and nutrition programming, as well as a proposed set of interventions. After that, I'll hand over to my colleague and co-author, Linda Schultz, to walk you through the remaining tools. Next slide, please. Before discussing the interventions, I just want to spend a little bit of time walking through the methodology, because of course, there's some feedback that has been received of, why are some interventions in there and why aren't others? So we conducted a literature review on school-based health and nutrition programming, and this included a review of the World Health Organization's guidance on adolescent health, as well as the DCP3 series that includes an essential package, an essential health package for school-age children, but this one was not focused on adolescents. So this was essentially, sort of trying to merge those two documents. But then we also continued that literature review looking for any evidence that fit the following criteria. First, that it included interventions that were targeted and appropriate for adolescents. So what that means is essentially that they responded to the specific needs and morbidities that arise during the adolescent life stage. Second, that they could realistically be delivered in a school setting. Third, that they are interventions for which there was evidence of effectiveness. And then lastly, that they were interventions that yielded, of course, demonstrated benefits, both in terms of health as well as educational outcomes. So, if there's an intervention you're looking for that you feel is missing, it may be because it didn't fit one of those 4 criteria. So yeah, that would be the reason that some of those were not included. We also list here mental health, chronic conditions, etc., that were not included. And this is not because they are not important. It's probably rather because there's limited evidence of their effectiveness in school settings. Next slide, please. So with that, the proposed package of interventions that's outlined in this tool is divided into two major categories, which you can see here on this slide. We have the physical health and nutrition interventions, and then we have health promotion and education activities. I will not go through each one of them, but you can see here that we've included under physical health and nutrition interventions, you have vision screening to reduce the risk of dropping out, repeating a grade, and performing less well on academic assessments compared to peers with normal or corrected vision. We include also deworming to reduce the negative consequences of helmets on school performance, grade repetition, and dropout. HPV vaccination for the prevention of cervical cancer, which is the 4th most common cancer in women worldwide. Intermittent iron and folic acid supplementation, and here intermittent means weekly, to reduce anemia, particularly among menstruating adolescents, and school feeding to increase energy intake, attention in class, and school enrollment. Then when we turn our attention to health promotion and education activities, we include comprehensive sexuality education, which has been shown to contribute to the reduction of unintended pregnancies, prevention of school violence, which can positively impact school retention and completion rates, menstrual hygiene and wash as an important measure to protect against wash-related illness, and also when we're talking about menstrual hygiene specific for increasing female attendance in particular. And then lastly, food and nutrition education and promotion of healthy lifestyles to support improved dietary and physical activity behaviors among adolescents. Next slide, please. We've also included tips and considerations for adolescent school health and nutrition programming, and you'll see this table as well as a modification of this table pop up throughout many of the briefs. We've included it also in the monitoring and evaluation brief, for example. And I won't go into excessive details, but I think, here the idea was really to highlight some important considerations on implementation modalities, which are going to be highly variable based on the setting. But they do hold important implications for implementation, specifically monitoring and reporting responsibilities, which can be important for decision making. So in this graphic, we give examples in the second to last row of which countries are implementing these different types of models. And then in the last column, perhaps most importantly, is what the opportunities and challenges are with each of these models. So I like to use that second example just to provide an illustrative example, which is where health services are provided by visiting personnel. And here we use the example of Mozambique. And the benefit of this type of model is that although it can be more expensive than the integration of services, it does allow for a broader range of services that can be provided because they are provided by specialized visiting personnel. So that's just one example of how to walk through this table, which, as I mentioned, you'll see various iterations of throughout the tools. Next slide, please, which I think includes my handover to Linda now. So
yes.
Thank you.
Yes, thank you so much. Thank you so much, Julie. I'm really happy to now introduce you to a brief in our series that focuses on the monitoring of school health and nutrition programs. And we wanted to focus on monitoring not only because it was a request from the focus groups, but also because we know that nearly every country in the world offers some form of school health and nutrition service. But simply delivering an intervention alone is not sufficient to improving the health of the learner as well as their learning. The interventions need to be high quality, delivered consistently, and relevant to the needs of the learner. And it's by monitoring that you have a proxy of progress to see whether or not your efforts are moving you towards the objective that you wish to see. At the heart of monitoring is the collection and assessment of indicators. And the selection of indicators is an important exercise because, as we all know, what gets measured gets done. but it's also what drives resource allocation. And the table that you see on this slide is an example of the type of indicators that you could apply for various school health and nutrition interventions that you could have across a results framework, whether it's input, process, or outcome. And if you're internal to the bank, it's also organized for the type of investment, whether it's a DPF, an IPF, or a P4R. What's quite interesting is that at an institution like the World Bank, you might not have more than one indicator that's specific to school health and nutrition within your results framework. But as you can see in these highlighted green boxes, there's actually quite a good history of school health and nutrition indicators being included in present and past World Bank investments. And if you're curious about which projects these came from, in our briefs, we do include the project number for all of these indicators, and we also have a much more extensive list that's in an annex. Julie gave a good overview of the types of delivery modalities, and this remains true in terms of how you would monitor and collect the data, because when you have your indicators, it then serves as a basis for your programmatic monitoring plan. And your monitoring plan essentially indicates who's collecting the data, at what time point and at what location are they collecting it, and how that information is then shared from the subnational to the national level. Julie gave a specific example from Mozambique about health services being provided by health service professionals. And so it makes sense that the information is collected by a health service individual, and then it aggregates across and goes to the district level health officer. When you look at the example that we have here for Malawi, this is for weekly IFA supplementation. It's a health intervention that's delivered by a teacher in the classroom. And then the information actually ultimately makes its way to both the Ministry of Education and the Ministry of Health. So you'll see that the data flows between the school to the subnational level at the district health office. And it's at that point that it splits, and then subnational information is shared with the Ministry of Education. And from the health side, it continues its way up until it's shared with the Ministry of Health. And this really helps for the information to be provided for decision makers. And also when it's done this way, it allows for these indicators to be part of the routine indicators that are collected by the Health Information Service. And that's a key consideration that we proposed as part of our brief, that indicators should be easy to collect and ideally already included as part of the health information system. You won't be surprised to hear that while we were in the process of developing these tools, we found ourselves in the midst of a global pandemic. And so we decided to respond by creating a resource that was very focused on what the health and education and social protection sectors could do to respond and sustain services that would typically be delivered in schools during this period of prolonged school closure. And obviously we're living in a very different world at this moment, but we do think that the information that's consolidated in this brief actually still has a lot of relevance, because there's many reasons why a school might be closed for a prolonged period of time. You have planned closures like a school summer holiday, but you also have other reasons why you would have an unexpected school closure. And that could be a climatic event, it could be a humanitarian emergency, or it could be another health crisis. The way that this brief is structured is we structured it as in advance of school closures, during, and a return to school, and what each of the three sectors could do at those time points. Each of these tables are then complemented by concrete examples of what has been done. And we drew very heavily from the experiences of success in West Africa from Ebola crisis. And so there's just many very concrete examples. And we do see this brief as a living document, as evaluations sort of come out as to what was truly successful in reaching students. Again, since we're now living in this sort of different space from when this was developed, I just want to highlight a recommendation of having an up-to-date contingency plan. Knowing that there are planned closures like summer holidays, the way in which students are reached using that blueprint can really serve as a foundation for an up-to-date contingency plan for how you continue to deliver services when schools close abruptly. So all of our briefs sort of conclude in the same fashion. We conclude with tips and considerations. And it's in this section that we try to summarize the key messages and ensure that each of our summaries are actionable. And what you see here is an amalgamation of what you would find across the briefs and an extreme simplification. But given what we've heard today, you won't be surprised that one of the key recommendations is to be very clear about whose role it is to finance, to deliver an intervention, and to monitor at each step of the way, and to select a delivery model that is aligns with the implementation capacity as well as the governance arrangements. Julie described 10 interventions that are suitable for adolescents in a school platform. These are very easily able to be packaged, and the benefit of packaging or piggybacking interventions on each other is that it allows you to maximize your investment, and it also achieves synergies and efficiencies along the way. Now, the interventions that you would select should be relevant to the learners. So you would look at the disease burden to make an assessment about what makes sense in your context. Another way to achieve efficiency is to train teachers as part of their pre-service or in-service training so that they're prepared to be called upon. And we were seeing many examples of technology being leveraged as a complement to pre-service or in-service training. And lastly, having a contingency plan. We saw during the COVID pandemic the importance of having one so that students, particularly the most vulnerable, are able to be reached. Here, this is a screenshot of the beginning of a decision tree. And this tool is actually quite different from the others because it's interactive. When we had our focus groups, what really came out was, how do task team leads who are maybe not from the health sector, how do they know what intervention should be included? How do they know how those would be implemented? A common question is, how are these financed? And so what we decided to do was create an interactive tool that would allow somebody in any situation to kind of identify a question that's most relevant for them and get guidance as a starting point. And I'm going to lower my screen so that Fernanda can put up hers, and we're going to walk you through a simulation. If you have the link open, you're welcome to follow along. We do recommend that you fully download it. Okay, great. It looks a bit blurry to me, Fernanda. Maybe if you hit start. Okay, perfect. So what you see here is that the decision tree covers 4 areas. So it covers policy, defining the package of service, implementing a package of service, and financing. And when I say it's interactive, what I mean is that you can click on any of these colored boxes and it will take you to the decision tree. So let's start with the policy tree. You can go ahead and click on it, and that takes you to a home page. And after you click on the home page, you're taken to a decision tree. So this decision tree is about policy, and you'll see that it starts with a holistic question that frames all of the questions that come after. Depending on the context that you're in, you would make a determination as to whether or not to answer yes or no. For the purpose of this demonstration, we're going to answer yes. From here, I see 3 follow-on questions. Given the context that I'm in, I'm going to choose 1. And for this presentation, I will have also chosen yes. And then from there, you can see that I have 4 questions that follow on from the prior. And I'm going to choose one. Go ahead, Fernanda. And because I have chosen yes in this context, it offers me actions to consider that are related to monitoring. So, you know, that's a very specific guidance to me related to the train that I took. Now, had I gone a different way and instead answered no, you'll see that I have actions to consider that are then offered. And these actions to consider are tailored to the question that was asked. So if I'm in a position where I am at a starting point and I don't really know what it is I'm meant to do, by answering no to any of the questions gives you very specific tailored responses to that question. If the interactive functionality is not your cup of tea and you would rather just go page by page, you can do that too. There are arrows in the bottom right. And you can click those and you will see that you can click page by page, but you'll also see that these are going to give you, you'll just recognize that the actions to consider for the no's are going to be quite different. And again, that's because they're tailored to the question. Go ahead. Okay, great. Now, if you would like to jump to a decision tree, sometimes the recommended action is cross-reference a different decision tree. You can then click any of those buttons in the upper right. And also, if you want more resources, you can click on the resource tab, and that will take you to a page for resources. And for the purpose of this demonstration, we will show you that for this decision tree for the design and implementation of an essential package, we have a series of resources about health promotion, for comprehensive sexuality education, for health service delivery, et cetera, and these are all hyperlinked. And this is also available on the Knowledge and Learning platform. Okay, thank you very much, Fernanda. Oops. Let me share my screen again. Okay, great. And just finally, before we go into the panel discussion, is brand new information. We will soon be offering 4 self-paced learning modules. This is an opportunity to sort of test your knowledge. The 4 align with the 4 briefs. And if you complete the modules, you will receive a certificate. When the modules are available online, we will send a note to everyone who is registered for this webinar. And it's a global resource open to all. Okay, should we pause here and just see if there's any questions in the chat?
There are
I encourage no questions so far, but I encourage everyone to use the Q&A option. Victor just signaled that that would be the best way to go about the questions. So, yeah.
Okay, great. Well, with that in mind, we encourage you to put questions in the chat, as Fernanda said. So why don't we go to the panel then, and then we can respond to questions following the panel. Okay.
Sounds good.
Okay, perfect. Okay. Okay, great. Well, I am delighted to invite our guests to join us as panelists. We are very lucky to have Fatima Berry and Jeannie Long with us today, and I'm just going to properly introduce them by telling you about their experience. So Fatima Berry is a health specialist in the health, nutrition, and population global practice. She joined the World Bank as a young professional in 2018 and currently supports health operations in West Africa focused on health system strengthening, pandemic preparedness and response, and maternal, child, and adolescent health. Due to her multi-sectoral background, she is also the focal point for health, nutrition, and population for school health and nutrition. She's also the West and Central Africa focal point for climate change and health, and leads the World Bank's neglected tropical disease work through Deworming Africa initiative. Jeannie is the director of the School Health and Nutrition team in the Department of Education and Child Protection at Save the Children. Jeannie has been with Save the Children since 2013, providing technical assistance to projects focused on improving the health of school-aged children in Africa, Asia, and Latin America. Due to the breadth of health issues affecting children, Jeannie supports programs to address the issues most salient in their context, ranging from WASH, malaria, comprehensive sexuality education, to road safety. Thank you again so much for being with us. I think we can start with one question to the both of you, really to kind of frame our discussion today. So if you would please give us an overview of your experience and what you see as some of the common challenges that you've experienced firsthand. Maybe we'll start with Jeannie.
Sure. Can everyone hear me? Great. Okay. As Linda mentioned, I have been working on school health and nutrition for approaching a decade now. And the uniqueness of school health and nutrition at Save the Children is that we are a small unit, but we sit within the education sector. So it's a very interesting place to be because our background is public health, but we sit with education colleagues and in our case also child protection colleagues. Save the Children, our work is on the implementation and operationalization of school health policy and programs that serve all school-aged children. And we say school-aged children because, as some of these publications acknowledge, that can be children in and out of school, and that age range really is determined by the policy. In many cases, that's 3 to 18. And so we do our best to consider those out of school children to the best of our ability when we're programming. School health and nutrition tackles a range of issues, and I'd say the most common ones for Save the Children center on WASH in schools, attempting to tackle hunger and nutrition, and we do quite a lot around menstrual health and puberty as kind of the earlier part of comprehensive sexuality education. And we consider school health and nutrition as contributing to Save the Children's ultimate goals and breakthroughs, which are to ensure children are protected from violence, that they survive and thrive, and that they have access to quality education. From where I sit, I think there are many challenges that nothing I'm about to say is going to sound new to anyone in this group. But in terms of adolescent school health and nutrition, some of our major challenges are that they're not all in school. And there's a lot of different factors that drive that. But sometimes one of them is also that the education sector, the capacity for the education sector to advance those students. And so we have one concrete example I'll talk about without like getting into the project name, is that we had a project that was funded by a large donor that actually worked on transitioning girls from primary to secondary school. And it was focused on all of these elements that we've been talking about: WASH, comprehensive sexuality education, gender, violence, gender-based violence. The project was designed, it was beautiful, it was really exciting, and then we got on the ground and realized that the secondary schools that were there either just couldn't handle the number of girls that were about to attend them, or they didn't exist. And so the project, actually a lot of the funding ended up going to just building schools. And so that's just an example of, we finally had a project that was looking at all of these different elements of adolescent health, and we couldn't quite implement it because the infrastructure wasn't there. So, and related to that is something that kind of came up a little bit in earlier, is that the opportunities to target adolescent health, it just doesn't seem to be an abundance of opportunities that really aren't focused outside of sexual reproductive health and rights. And some of the other health issues that really affect high morbidity and mortality of adolescents, like road injuries, like mental health. that you mentioned in your report, they need more investment. We need more evidence. And so it's unclear whether there's a lack of evidence to support these interventions or whether there's a lack of investment to build that evidence. But I think that just acknowledging that the opportunities to work and these to combine some of these interventions often isn't present in a lot of the projects that we see, at least on my side. And finally, on the monitoring side, I think for adolescent nutrition in particular, we know that there's a difficulty in measuring nutritional status for a certain age of adolescence. And I know there's a lot of research going into how to do that, but which was mentioned earlier, if you don't have an outcome to show that you've reached a result, then it's hard to advocate for more resources in that area. So since we can't very easily measure nutritional status for especially younger adolescents, how do we know that we've done it well and that we've done it right? And so how do we then get more investment in that space? So there's a difficulty of measuring certain outcomes for this age group. Mm-hmm. And lastly, with the data and monitoring, there's a lot of still reliance on paper. Reports aren't often timely. And so how do you make decisions in a timely fashion that allow you to improve the system, to improve the platform, in a more agile way? I think we haven't quite gotten there in a lot of contexts. And even saying we know that, if at a school we manage to connect the school to a health clinic, how do we know that the service that we've referred them for, that the child actually gets, that there's follow through? So there's a lot of just gaps in the data management and the monitoring of services that we see in many places. So those are just a handful of some of the challenges that we see for school health and nutrition more broadly. Thank you.
Jeannie, that's so helpful, and you're right, it really rings true. It rings true also in what we were seeing as we created these briefs. Just your last point about difficulty in collecting and then tracking down the data. It was also very difficult just in the creation of the brief itself. We found such limited information that we actually published a paper separately on it because we just felt like there was a real miss in the space. I'm going to now ask the same question to Fatima.
Okay, thanks so much, Linda. And thanks for inviting me again to speak today. It's really wonderful to see all the efforts that are really being put into helping countries create a safer and healthier environment for children and for adolescents in schools. So a little bit on my background, especially since I arrived at the bank, it's really been focused on strengthening the NTD programs, neglected tropical diseases programs. And in that space, it's really important to go beyond the health sector. That's something that's always been key. And this is why school health and nutrition services really is a big part of the work that we are doing. Now, in terms of some of the challenges, as Jeannie noted, there are many, right? So, we don't have the time to discuss all of them. Maybe the one that I do want to discuss today is really related to some of the lack of stewardship, the ownership, and sometimes even the accountability in school health and nutrition programming for adolescents. So, one thing that is very clear in countries is that usually there are two main actors. You'll have the Ministry of Education and the Ministry of Health. In some instances, maybe you'll also have a Ministry of Water or that is engaged in school health and nutrition. However, coordination tends to be very weak. Roles and responsibilities are usually not clear. There's a lot of fragmentation, and sometimes this really lacks from a very well-defined national policy to implement school health and nutrition programs. So you really need that strong political support sometimes as well. And if that doesn't exist, things don't move, it doesn't budge. And in countries where policies do exist, sometimes they exist maybe in one agency. Maybe it's just the Ministry of Health or just the Ministry of Education. And so that really tends to not be domesticated. And then it leads to this lack of accountability, or even the lack of measured progress that we would like to see. You'll also see some really the type of interventions are very limited in scope. There's also maybe not really a sustainable lens that's included within this. So some of the work that we're doing through the Deworming Africa initiative, we're supporting a few countries, and some of our grantees are, for instance, Niger, Angola, Central African Republic, and Sao Tome and Principe. And so there are specific activities that we were able to work with some of the TTLs to really try to see how to ensure not only better coordination between the ministries. So there are workshops and various meetings that are taking place to really try to advance in this question. And this allows them to really define the roles, to develop training materials and curriculums together. And sometimes it's also, how do we ensure the interoperability of the data systems for school health and nutrition? Because remember, this could be data that could be useful not only in the health information system, but also in the education information system. Sometimes this also includes the development of plans for the integration of several school health and nutrition services. And also, as Linda noted, that's a key point in the decision tree is the financing of the school health and nutrition services, which is really important. One of the other key challenges, and I think Jeannie really discussed this very well, is really the gaps in data and research. And I agree with Jeannie as well that parts of that is really linked to the lack of adequate financing, right? So, and lack of adequate financing, we should say, in multi-sectoral efforts, right, in various countries. So there are a number of tools that have been available in the last 2 decades, especially as it relates to school health and nutrition. You know, we can start off with, for instance, the FRESH framework. There have been impact evaluations done by various UN agencies, such as WFP. We had also the school feeding and the school health SABERS, which is systems approach for better education and results. So there are a number of these tools, but sometimes if there isn't that political will, that stewardship, there isn't the financing, it's hard to get these things moving. Right. And more recently, we also have my team and I are working on the Healthy Saber. We're working on this with other partners, including WFP. And it's really trying to make it more comprehensive. How do we really get all the different stakeholders engaged to really try to use a diagnostic tool to help really understand the coordination challenges, the governance challenges, to really find a way to do a plan of action. And this tool is currently being piloted in Togo, right, to really try to allow the country to determine where it stands and what type of actions they need to take to move forward. And I think that the tools that were presented today are very complementary to that, right? The tools that we've seen today really allows people to, or countries to identify some of the missing pieces to a holistic school health and nutrition program for adolescents. So really, I think it's very clear that there needs to be more financing going into data and research to allow countries to really go ahead and do the studies that they need to do to advance the programming. And so some of our grantees that I discussed a little bit earlier also we're supporting them in these studies, in these analyses, and sometimes even other data needs, right? For instance, in Angola, they're looking into how to better integrate school health and nutrition data through the information system, right? So we're providing financing for that to allow that to happen. So I do think that there's a lot of challenges, but there's also been a lot of advancement in this area. So I'll stop there. Thanks.
That was wonderful, Fatima. I'm so interested in what you were saying about the organizing the workshops to agree on operationalizing actions in a country level, because it really relates to a question I was going to target to you. And I'm conscious of time, so maybe we can just very quickly, I'll just ask you, as now that you've had this experience doing these workshops and operationalizing Healthy Sabere or piloting Healthy Sabere, when you think about those experiences and you look at the tools that have been developed, what pain points do you feel, if any, have been reduced, and what's missed?
Thanks, Linda. Yes, so first of all, as I said, the various briefs and the tools that were presented today, I think are going to be extremely useful. And part of that is that it really allows one of the main pain points, which is the lack of guidance, evidence-based guidance, right? And through these tools, teams will be really able to get the information that they need, right? This includes examples of what's being done in other countries, what has worked, what hasn't, right? For instance, I think Julie was discussing the different modalities that countries could use to go ahead and have school health and nutrition services in schools, whether it is if countries want on-site personnel, visiting personnel, they're able to see the different examples from different countries. So I think that's very important. The other thing that's really great to see in the tools that were presented today is the fact that it's very versatile, right? It can be used by any country, any stakeholder as well. I don't think it's just, TTLs or task team leaders. It really allows countries that are maybe at the initial stages of school health and nutrition programming, or even at the advanced stations, to really try to figure out how to implement a holistic school health and nutrition program for adolescents, right? The other pain point I think that's been very well addressed is, there's always competing priorities, right? And I think in the health sector, we tend to really focus on a package of essential services. And I think we're able to now see that even in the school health arena, that's also a possibility, right? You want to be able to seek out the opportunities where the services can be provided in a combined package, and the guidance in the briefs and the decision tree really allow teams to really get a better understanding of that. For instance, there was an example in one of the briefs related to the HPV vaccine and what else could be done with adolescents during that time, such as vision screening or deworming treatment, vitamin supplementation. So this is really important. And I think, we mentioned this as well, but this is really important because it really incentivizes parents to send their children to school, right? Because they're able to see that there are other benefits to sending their children to school. They'll be able to get some of these services, these health services as well. Just because I know there's time constraints, so I'm not going to go into other things in too much detail, but Linda already discussed a lot of the work that they've done, for instance, as it relates to the pandemic and what needs to be done when there are health emergencies. And I think that that's a very key point. One thing that I think, and I think as we continue to work in this area that may be quite useful for us is even more of a deep dive for some of the actions, the actions that are considered or to consider that were, for instance, in the decision tree. I think giving more details as to what is a landscape analysis, what would that look like in a country, and these type of things, I think that would be definitely useful. The other thing as well, we would love to see, now that these tools are available, having people use them, really try to hear in the next few months, how do they think it's useful? Are implementing agencies maybe in the country also able to use them, and do they find that useful as well? So I think as we continue to move forward, hopefully we'll get a bit more information on how effective these tools can be. Thanks.
That's great. Thank you so much, Fatima. And you're absolutely right. There is opportunity to go deeper in some of the suggestions. The example you gave is a great one. What does a landscape analysis look like? Hopefully the resources tab offers some insight, but obviously it won't capture everything. I'm really glad to hear that when you look at it, you see that it helps to address a pain point in guidance. That gives me some peace. Jeannie, I'm going to turn to you. Now, Save the Children works to support the implementation of these interventions, often with the support of in-country stakeholders. And when you look at the brief end, there's these tips and considerations. I'm just wondering, like, how well it resonates with your experience, because we aimed for these to be actionable, but you have the most experience amongst us of taking these actualizing school health and nutrition on the ground.
Yeah, I think I actually Fatima and I did not exchange notes, but we should have, because we have almost a lot of the same things to say, which is the practicality and the efficiency of bundling interventions, of seeing what other countries have done, is really key to a lot of our partners, and being efficient with how you combine initiatives. I think the decision tree is actually really exciting, and I'm like super nerding out about getting into it. I hope to explore it a little bit more, but I think it's a really engaging way to get people to think through the steps that they need to take. I'm working on a project that looks at SHM policy, and 4 countries that have a SHM policy in sub-Saharan Africa, and they're all completely different places. So like that kind of document is really important to see, and we will be using it. So I think the one thing that I guess you didn't quite ask me, but I think I wanted to share in terms of 2 tips that I might have for folks who are working in this space now that you've seen this guidance, is number 1, I think, and I hope I'm not jumping ahead, Linda, but I feel like a lot of us feel like, oh, well, we're not getting funding for this. Like, how are we going to implement this type of work? How are we going to take some of these suggestions and apply them? And I think we forget that a lot of us are already working with adolescents in some way, right? Most of us who work in primary schools are working with that younger, very young adolescents, ages 10 to 14. And where we have the chance to integrate some of these other school health initiatives, where we have that flexibility, we should try, because we're already reaching them, and we might be able to build some evidence that way. Layering projects, or looking at ways to layer one type of financing on top of another, so that we can finally integrate like school safety with WASH in schools, and really try to build that up. I think that's one. We have now the tools that we need to see how that could work. Let's see if we can leverage our existing projects and our existing reach. And then the second is, something that came out of an internal landscape analysis we did at Save the Children that looked really specifically at adolescent nutrition, but I think applies to this too, is that the comprehensive sexuality education space has really figured out how to reach adolescents, how to engage adolescents in health related issues. And so how can we apply some of the knowledge from that space to these other issues like food and nutrition, vaccination, and other types of health services that we want adolescents to seek. And so leveraging that really big, strong knowledge base to these other areas, I think would be another way that we can leverage these tools and these tips in the work we already have. So I hope that's helpful.
That's a great point. And actually, I don't think it's one that we articulate in the brief. So it's a really, really great point. I really appreciate you raising that. I'm surprised. I wish I had thought to put it in the brief. Fatima, do you want to end with a quick tip that you might offer the audience?
I think that Jeannie covered it, really. I think there's so much to do in this area. And I do think people should take the time to really read the briefs, go through the decision tree. I agree with Jeannie. It's nice to have that, to be able to go through. So hopefully people have the time to do that. Thanks.
Okay, great. I apologize. I know we're past time, so I'm going to ask Brendan and Julie to guide me as to whether we should wrap up or if there's questions, because I actually can't see the chat.
Yeah, so we actually had one chat from our colleague in Mozambique. So thank you, Sara, for that question. I think maybe if we can take just a few minutes, if the panelists want to try to respond to it. This is a challenge that has been raised, but is specifically in terms of the communication between the education and the health ministry. So Sara is working specifically on Mozambique, on their school health programming. And she says, yeah, the teams came across challenges originated from cultural issues, where communication between the education and health ministries is not flowing when it comes to the administration of injectable contraceptives and how these barriers were overcome. So again, I think some examples have been provided. I think also Brendan responded to the question in the chat, but maybe if we can just, like, let's say we'll close in 3 minutes and we can at least just address that one question in the chat. Thanks.
I don't know how helpful I will be, Sada, but just to say you're not alone, and that we've seen success in Uganda, for example, with like HPV vaccinations in school, which are done through the Ministry of Education, but really facilitated through, is implemented through the Ministry of Health, but facilitated through through the education sector. But I can imagine injectable contraceptives are probably much more sensitive, much more, there's a lot of communication and health promotion that needs to happen around them that focuses on what is culturally acceptable by families in terms of talking about sexual activity versus, you know, preventing adolescent pregnancies and that kind of thing. So what we have acknowledged is that in most of the countries where we work, the education ministry is much more conservative than the Ministry of Health. And sometimes that can affect the interventions that need to be delivered in schools, because how does the education sector communicate those things? So I think how they communicate and promote that, that health initiative is key to the acceptance from communities. And often there's just fear that there will be backlash. So I don't know particular in Mozambique, but just to say, like, this is not a unique, it's not unique, you're not alone. And this is a struggle. I don't know if Fatima has anything to add.
Yeah, no, just to add to what Jeannie's just said, definitely not alone. I think this is something that happens in a lot of the different countries that we work in. The key thing here is sensitization, really, and carrying along all the stakeholders from the beginning, right? So the Ministry of Health shouldn't just be making decisions about what they think is best, but really kind of carrying along also the Ministry of Education or any other ministry that would be involved in this, right? So it needs to be sensitization at these implementing agency levels, but also in the communities themselves, right? Ensuring some form of social behavioral communication as well. So these should be activities that are being done. Now, once again, it goes back to the lack of financing, right, in these areas. How do you make sure that these things are happening at the same time? And if there is a way to do those efforts, and for different agencies to work together to make sure to implement some of these activities, I think there would be an easier way to have these discussions and really start to see some progress as it relates to these services in schools. Thanks.
Okay, thank you. I think maybe we'll just jump ahead just to our acknowledgements to all the folks who put in a lot of time to making these tools possible. So I'll let Brendan just close us out.
No, thanks very much, Linda and Julie, and thanks very much to our panelists for making the time today. Just really quickly, I wanted to extend some thanks to our extended task team, including Charlotte and Supriya, who have joined us online, but also in particular the peer reviewers for this work, both internal and external, and the task teams and task team leaders that participated in the focus groups that kind of formed the basis of this work. We really appreciate all of the time and effort that everyone put into this set of tools, which I think and finally, Julie and Linda, I think you did a remarkable job trying to translate the needs that were communicated by these various stakeholders into some really impressive tools. And I really suspect that they will be very useful as task team leaders engage in a policy dialogue with their clients, support project preparation, implementation support, restructuring to projects. And so congratulations to the two of you. So thanks very much.
Thank you, everyone, for joining us today. And thank you also to the team who allowed this to happen, Fernanda, Victor, and company. Thank you, everybody.
Thank you, everyone.
Thank you.
Thank you.
Thank you.